Right, we'll get started. So thank you all for joining us tonight, especially on this beautiful evening. My name's Charlie Lay. I'm one of the tissue viability nurse specialists with Coloplast. My background is, I've been a nurse for 16 years, but my background is in tissue viability. So I'm going to be manning the chat today. Rommel, I'll pass you over to in a minute, is going to be delivering the education today. So I will put some questions in the chat. Please feel free to answer them as we go. If you've got any questions, please just ask them in the chat and I can answer them as we go, or we can answer them at the end. You will get a copy of this recording. You will also get a certificate and a copy of the pathway at the, after the event. It won't be immediate because our team's got to send it, but you will get it in the next week or so. So I'm going to hand you over to Rommel and we'll get started.
Thanks, Charlie. Right, let me share my slides. Okay, hopefully it's loading up now. Can you see it loading up, Charlie? Or...
Yep, I can see it loading.
Okay, it's thinking about it. There you have it. There you have it. Okay. Let's start from the beginning. Right. So before I start, good evening, everybody. As Charlie said, thank you so much for spending your evening with us. It's so lovely outside. So, and I think from my point of view, this is your hour with us. So this is an educational session this evening around antimicrobial stewardship in wound care specifically. So my name is Rommel Ulrich and I am one of the tissue viability nurses here at Coloplast. My background is trauma and orthopedic, and I've been a tissue viability nurse for over 20 years. So I'm getting on a bit. I started my career as an acute tissue viability nurse and then progressed. And now, fortunate enough that I've got a dual role here in Coloplast. So I carry a caseload. So I run a complex wound care clinic and I am in clinic 2 days a week. So clinically, I'm very much still relevant. So I practice what I teach, really, is what I'm trying to say here. So, right, let's get going. So the objectives of this evening session is I'm going to walk you through what is antimicrobial stewardship in wound care. And I think that's the main thing, and that's the purpose of this session. Whilst I do that, I will introduce you with the three-step approach that we develop here at Coloplast. We as a company, we are all about simplifying wound care. And this three approach is really encompassing or summarizing sometimes the complexity of what wound management, what wound healing is. So when we're talking about assessment, preparation, and treating a wound. So it's quite easy to remember. So that three-step approach is going to be the assessment, preparation, and treatment. I'll be repeating it again and again. There's always a bonus about repeating. It's about retention. Whilst we do that, we'll be talking about how we manage wound, and it's not just about wound management, but we're dialing that conversation up to the wound healing. So we're not talking about wound management, but wound healing if we can. We're also going to walk you through about the understanding of what a wound infection is, particularly in relation to biofilm. And whilst we do that, give you some hints and tips on how to manage a true wound infection and biofilm. We were going to walk you through what is the best practice recommendation from the International Wound Infection Institute and the importance of practicing antimicrobial stewardship. And at the end of that, as a summary and as a guide, we here at Coloplast, we're going to send you a copy of a pathway that follows the three-step approach that we develop about assessment, wound preparation with a guide in terms of where to use some of the products that we have here at Coloplast, for example, the All Prep Pad, and treatment using our biotin range. Right. Please allow me to set the scene. Currently, if we're looking at evidence, Guess et al., one of the most famous, I think, well-respected health economists here in the UK, is approximately about 3.8 million patients currently has got a wound that we are currently managing. It's probably more now because this data is probably that was published in 2017 and 2018. Out of those 3.8 million patients, in terms of spend and cost to the NHS, approximately we're talking about 8.3 billion. And that is a significant amount of cost. But if we're looking at where do we spend this money in particular, 2.7 is spent on healing wounds. So this is about healing wounds, but a significant proportion of that is double the amount of that. 5.7 is spent on just managing wounds. So if we imagine it, managing wounds is more costly than healing wounds. So that's something that we have to bear in mind. And if we're looking at wound healing per se, 59% of those chronic wounds that healed during the study period, there was no evidence of wound infection. However, 45% of the non-healed wounds, which is a significant proportion of the 100% cohort, have a wound infection. So truly, if we're looking at the data, wound infection is a significant problem that we face in wound care. When we surveyed healthcare professionals about the challenges of wound infection and how they find wound infection in clinical practice, I'm actually surprised with the statistics. About 46% of healthcare professionals believe that infection is a challenge. I think it should be higher than that. Maybe some of the reasons behind that is the acknowledgement and the knowledge of how to diagnose a true wound infection and the complications of wound infection. And for example, on how to manage or what is an antimicrobial, for example. So the take-home message for this slide really is expensive in just management of wounds. We need to heal wounds. It's a more cost-effective way of doing it. I'm not even talking about quality of life of patients. So what is the clinical relevance of wound infection in practice? The world we live in is full of microorganisms. It's all around us. And we're having to navigate the balance between the host response, the patient's response to microorganisms. So if microorganism is around us and we've got patients that are vulnerable, we're having to navigate on how to prevent our patients with wounds, on how to manage those infected wounds. Because if we don't get it right, what happens in clinical practice is, number one, delayed wound healing. And what does delayed wound healing means? Patient quality of life can be adversely impacted. Then the treatment goes up. This is when clinicians with faced with infections, particularly maybe the knowledge around wound infection or the use of appropriate antimicrobials is really there that will try and reach out immediately for antibiotics. Now, I see in daily practice, I saw a patient this afternoon with a sternotomy wounds. It was overgranulating wounds. Prior to coming to clinic, he had four episodes or 4 treatment doses of antibiotics because they felt that this wound is not healing purely because they suspect that it is a wound infection. But in fact, it is an overgranulation tissue that needs to be managed. So thereby, what we're looking in clinical practice is what we call that antimicrobial resistance, particularly if we're talking about antibiotics. So what is antimicrobial resistance? Now, antimicrobial resistance occurs when the bacteria or viruses or fungi or parasites no longer respond to antimicrobial medicines. When I say antimicrobial for the purpose of this session, sometimes it can mean antibiotics or antimicrobial dressings or antiseptics. Those words are interchangeable when we're looking at treatment of wound infection. Antimicrobial resistance is generally, I think, if we look at it, if we look at our own practice, healthcare professionals, we have to take ownership of it because this happens when misuse and overuse of common antibiotics are being prescribed to patients or poor infection control practices by us. And there is a lack of new antimicrobials being developed currently. And as a result, drug resistance happens. And when you got a patient with wound infection or other form of wound infections, and they've got certain resistance to different types of systemic antibiotics or oral antibiotics, for example, what happens is they are impossible to treat. The disease will spread, severe illness will happen, disability, or sometimes death. More often than not, death. So this is a real problem. And it's not just a UK problem, but this is a global and public health problem. It's one of the top 10 global public health risks that is currently being registered. Again, more statistics here, if we're looking at antimicrobial resistance. It's directly responsible for about 1.27 million of global death that was recorded back in 2019. And I think those are preventable deaths. If we have the right antibiotic treatment, highly likely those patients would still be alive by now. So we need to act now. It is predicted that in 2050, 10 million individuals will die because of antimicrobial resistance. And that is a real issue. And antimicrobial resistance doesn't discriminate about age, or what you do, and what type of disease condition you have. It's It depends on what type of microorganism is causing that infection. So really, as I said, we need to act now. You're probably sat there thinking, well, what can I do, Romo, in wound care? Now, in wound care, sadly, what I see in clinical practice is the misuse and sometimes overuse of antibiotics and antimicrobials, purely because of the lack of knowledge and the lack of recognition of wound infection. So therefore, we need to do our bit. Now, I am delighted that you are all here this evening, purely because this is what it's all about. It's about that recognition of what the true problem is, so that we can appropriately treat these patients either with antibiotics or antimicrobials. So us as a healthcare professional, we need to be aware about it. And it's not just individuals. This is a multidisciplinary approach. There's no point Charlie doing her own antimicrobial stewardship in her own clinical practice and me doing completely something different. Everybody needs to be aligned. So if you are working in a team that's not here this evening, make sure we pass the message on, because this is about antimicrobial stewardship. And that what stewardship means is about us healthcare professionals be aware about our own actions. And sometimes we have to reflect on our own practices to avoid those ritualistic practices. And sometimes, the prolonged use of antimicrobials in certain patients, or immediate knee-jerk reactions of reaching for antimicrobials or antibiotics. There has to be some element of good, accurate assessment when we're looking at identifying wound infection. Element from that framework when we're managing a wound. We hear about accurate assessment all the time, and we're being encouraged to do accurate assessment, not just in wound care, in everyday lives in nursing. But what the assessment means from a wound care perspective, from my point of view, the number one thing, we must get it right from the get-go. When we see a patient, particularly with hard to heal wounds, we must identify the true etiology of the wound. Now, I repeat, the true etiology of the wound. More often than not, hard to heal wounds or chronic wounds are a symptom of a disease. So what does that mean? A symptom of the disease. So for example, we say diabetic foot ulcerations. The key word is there in terms of the underlying etiology of that wound. It's because of diabetes. Venous leg ulcerations, venous leg ulcer. This is a venous leg ulcer. So we need to identify the true etiology of the disease. Otherwise, you will never get the care plan correctly. What I say to you is, if you are seeing patients in a regular basis with hard to heal wounds, complicated wounds, and you stood there and you're just thinking, right, what is the true etiology of this wound? If you're completely blank, you don't know, I would encourage you to refer, because this is the very foundation of what a true good management could look like. So always identify the true etiology of the disease, control some of the wound-related symptoms, identify some of your patient expectations. They walked into my clinic and someone says, right, here it is. Heal my wound, please. It's been there for 2 years. I've got a holiday in 4 weeks' time. And I just think, well, I'm good, but I'm not that good. But I always manage their expectations. Okay? And get them involved in their care at the same time. And be sympathetic, provide some psychological support to those patients that are suffering with hard to heal wounds. More often than not, sometimes I see patients that they've got their wounds for 8 years, 10 years, 15 years. Not acceptable. There are wounds sometimes that could potentially be there because of other factors for a prolonged period of time, but majority of the time we can treat these wounds and we can heal these wounds if we accurately get the right etiology from the get-go. Okay? Ooh, pressing the wrong button. There we go. Come on, move. Right. So we've identified the potential etiology of the wound. If you are listening to this webinar and you work in the acute setting, Some of the risk factors that's worth noting when we're looking at wound etiology is the type of wounds that we're seeing. Now, when I say contaminated or dirty wounds, that means there's potentially some spillage of either gastrointestinal tract during surgery for those acute wounds. When you see, for example, open laparotomy emergency bowel spillage, dirty wound as they class it, we know from a risk factor perspective, this wound could be a high risk of wound infection. Significant amount of trauma, so traumatic wounds with delayed treatment. When I say delayed treatment, either delayed surgery because they're not fit for surgery, there was some delayed intervention. This patient will be high risk of wound infection. Inappropriate hair removal, prevention of SSIs. If we don't practice them, wounds will be so high risk of wound complications, particularly from an infection perspective. Chronic wounds or hard to heal wounds, the degree of chronicity, how long has that wound been there? The longer we leave the wound open, the more risk these patients are going to be at risk in developing wound-related wound infection. So from my perspective, when we talk about treatment of wounds or managing of those wounds, I always have this in mind that the goal is we need to close this wound as soon as possible, because I know the longer we leave these wounds, the more difficult they are to manage and they're high risk of wound infection. It makes sense. In combination with acute and chronic wounds, if this wound at the wound bed is covered with devitalized tissue, we must know what a necrotic tissue is, a slough, a hematoma. So if a wound bed is covered with devitalized tissues, they are high risk of infection. They are portal of infection. Bacteria likes to feed on those dead tissue or hematoma that are present in the wound bed. Thereby, we must remove them. Other risk factors of wound infection, if we're looking at it from an individual factor, I think these are the individual factors. So those are some of the risk factors that we need to be vigilant from an individual perspective. So when we're assessing the patients, when we're trying to get past medical history, digging what type of medications they're taking, we must acknowledge, for example, diabetes is one of the risk factors that can predisposes them to an elevated risk. Patients with immune system disorder, inappropriate antibiotic prophylaxis use, patients that smokes, alcoholism and drug abuse. So those are patient risk factors. What can we do? Support those patients. It's about patient education. It's about managing those comorbidities. If they got poor diabetic control, refer them to nutritionists, diabetes specialists. Patients with high levels of blood sugar, bacteria love sweets too, not just me, but they do. So those patients with elevated blood sugar can predispose us of high levels of potentially in terms of risk of wound infection. Optimize the nutrition status of a patient, increase hydration, encourage good nutritional support, educate the patient. Easier said than done, but we must try from a patient perspective. Next is environmental risk factors. Hospitalization is one of them. It's, again, somebody in clinic today, they'd like to come to clinic regularly versus doing their own dressings because they felt that my clinic is safe and less risk of wound infection. And when I explained to them, well, actually, visiting the hospital regularly for wound care, which is not acceptable, or visiting a clinic when we're looking at risk factors is elevated versus them doing it at home. If you run a clinic or in hospital, patients come in unwell with different types of wound infection, bringing their own bacteria, viruses, fungi. So therefore, the risk is elevated. And when you explain this to the patient, they probably think, well, actually, all right, teach me on how to manage my wound. So it's some way of reducing that risk. Unhygienic environment, poor hygiene and aseptic technique. Patients, when they're doing their own wounds, you don't need a full aseptic technique. A clean, non-touch technique is enough for them. It's about that patient education. Okay. General good measures. Again, education plays a big part here. Why do we need to reduce the risk of wound infection? Or how do we reduce those risks? We know, I think, why. Because we don't want the patients to develop wound infection as a complication. But we need to do this to optimize, and one of the strategies of optimizing that individual's host response. We need to make sure our patient is strong enough to combat wound infection or any other microorganisms that are around us. Reduce local microbial burden at the wound bed. And that we're promoting a positive environment for wound healing. Because if we don't get it right, and if the patient don't get it right in terms of optimization about their health, the environment, wound infection can happen. And to assess a wound infection, this is one of the framework. We like things to come in threes. It's easy to remember. We have to focus on these three elements when we're doing wound assessment. Focus the wound bed, the wound edge, and the peri-wound skin. The peri-wound skin, I mean, it's about 4 centimeters from the wound edge up to the surrounding skin. So this is where we need to guide our detective eyes in terms of assessing for signs and symptoms of wound infection. Right, so let's look at stages, I think. The next slide would be, yeah, there you go, the stages of wound infection. Now, I'm going to try and talk slow here. I would like to direct your visions at the bottom bit of the slide. So there are, what can you see? 5 stages here of wound infection. Not all, I would say, is a true wound infection, okay? Purely because we're looking at, from an infection point of view, this is about the level or the virulence of a microorganism versus the host response or the patient's response is what a true wound infection would look like. So we'll be going through bit by bit of all those 5 stages of wound infection. And above that, if we recognize it as another stage, so that's going to be the 6th stage, you can see there's an arrow above called biofilm. So we're going to touch on about biofilm, because biofilm related wound infection can happen at any of those stages, from colonization right up to systemic infection. Okay, shall we start with wound contamination? Right, wound contamination means if you fall over for whatever reason by accident this evening, after a few glasses of wine, when you finish this webinar, you fall over, sustain a graze on your knee, that wound, because flash news, we all have commensal bacteria in our skin. And as I said, microorganisms around us. Immediately, highly likely, will be contaminated. What does a wound contamination look like? It is the presence of microorganism or a bacteria at the wound bed, but this bacteria is not multiplying. It's just there, happily living, not multiplying, not bothering you, not bothering the wound, and the wound continues to progress. So this is what wound contamination would look like. Now, do we need to treat the patient at this stage? Possibly not. Absolutely not, is what I'm going to say. That's what wound contamination would look like. So when you see a wound swab and it says possible contamination, Pseudomonas aeruginosa, don't be alarmed. Don't ring the GP immediately to say, I need some antibiotics here, there's some contamination. Because contamination means what? Non-proliferating microorganisms. They're just there, not causing any problem. Okay? Next stage is colonization. This means that the wound bed, or there are bacteria at the wound bed. So in this particular stage, they're undergoing limited proliferation, limited. Small amounts, they're multiplying in a slow amount. But the host, because the patient is strong enough, has got no reaction. So there's no host response from the proliferating microorganism at the wound bed. There's no reaction there. So that means that the wound is continued to heal. There's no delay in wound healing at this point. Again, you will see this in some of the wound swabs when you're looking at it. It's a possible colonization. Now, we will talk towards the end of the presentation, we'll talk about prevention or preventative measures on what we can do to proactively prevent tipping that balance from colonization, because the next stage now we'll be talking about local infection, on how to prevent that tipping by doing different strategies from a wound preparation and treatment perspective. But really, if we focus on this for now, potentially no need for antimicrobials. The next stage is what I'd like you to be vigilant about. This is local infection. Now, local infection means that the microorganisms proliferate and move to the deeper tissue into the wound bed, causing a host response. So this time, the patient is reacting to the proliferating microorganisms at the wound bed. And those responses can be different signs and symptoms of wound infection. So this is what we need to master, hopefully this evening, in terms of looking at those true signs and symptoms of wound infection. Because at this point, this is when we potentially would reach out for those antimicrobials to help manage the microorganisms and get that wound to a potential healing trajectory and prevent delayed wound healing. So what are the signs and symptoms of localized wound infection? If you qualified how many centuries ago, you probably would have encountered what a terminology called critical colonization. Okay? That definition is obsolete now where we're looking at local infection. But exactly what we're, the signs and symptoms are exactly the same. We split it into half, or the subtle symptoms, or the covert signs and symptoms of local infection, or the classic symptoms. Let's go with the classic symptoms first. This is something that I'd like to think that we're quite familiar with. Erythema at the wound edge of the peri-wound skin. You feel heat coming from the wound during palpation, swelling again during palpation, purulent discharge, delayed wound healing, increase or sudden increase in pain and malodor. Those are some of the classic or obvious signs of wound infection. When you see that at the wound bed, local signs of wound infection. Okay. The other signs and symptoms are the subtle signs, particularly when we talk about long-standing hard to heal wounds, closely linked to biofilm-related wound infection as well. It's called hypergranulation, so overgranulation tissue. Granulation tissue that bleeds easily. So it bleeds easily. Epithelial bridging or pocketing, wound breakdown, delayed wound healing, increased malodor and pain. In combination, if you're seeing those type of signs, not necessarily all, some of those signs and symptoms at the wound bed, but you're seeing that the patient is reacting. That means delayed wound healing, the patient is in pain, there's a malodor, local signs of wound infection. We need to manage it. If we don't manage it right, this is when it tips to spreading infection. And spreading infection can be detrimental to the patient's health. This is when the patient will elicit some systemic signs. When I say systemic signs, at this particular stage, the patient might feel a little bit unwell. So they will say to you, for example, I'm feeling a little bit under the weather. Okay? I've got loss of appetite. I don't really have much appetite to eat. I feel tired, a little bit sleepy. So not the usual self. And then you've got a delayed wound healing going on, or local wound infection. So once the patient will verbalize some of those signs and symptoms of systemic signs, of beginning signs of systemic infection, this is when we need some antibiotics more than topical treatment. I think we need some systemic rescue here. If we don't, it can spread into a systemic infection. Now, what systemic infection could mean is that you will now be seeing here tachycardia, increase in heart rate, tachypnea, increase in breathing. This is when we need to send the patient to hospital, absolutely. Because these patients will need blood culture, blood tests. We're looking at infection markers, what type of microorganisms, it needs specific targeting for wound infection. But really the lesson here is we need to treat the patient when they are showing signs of local infection and be vigilant of those spreading signs of wound infection. Biofilm-related wound infection, as I mentioned earlier, is another stage or another type of wound infection that is very common when you are treating a patient with long-standing hard-to-heal wounds. It can happen at any stage. What that means is, what is a biofilm? It's an infection or a bacteria when in this group of microorganisms have develop this form of protection around themselves. Bacteria is getting, or microorganisms are getting a little bit more smarter now. Okay, so what they do is they develop this extrapolymeric substance around themselves to protect them against antimicrobials or antibiotics that you're delivering. How I explain this to the patient is any microorganisms at the wound bed, they will treat it as their home, and they will do everything they can to keep that wound open. Hence, they form this protection around themselves and push the edges of the wound margins to keep the wound open and to keep the wound in the low levels of inflammation. So it's not that obvious, the sign, because they don't want to be spotted. They're very clever. They want to stay at the wound bed, and it's important for us to recognize them because they are ubiquitous. They are everywhere in nature. It's one of the most common infection causes, really, complications, not just in wound care, but any other disease conditions. If you are treating, if a significant proportion of your caseload is leg ulcerations, for example, diabetic foot ulcers, long-standing pressure ulcers, and this group of patients have received different types of antibiotics, highly likely you'll be dealing with a biofilm-related wound infection. And these are some of the signs and symptoms, those subtle way of wound infection. They're almost trying to hide from your assessment and from you spotting them that there is this wound infection going on. So one of the signs and symptoms, again, is that delayed healing. Long-standing wounds, 3 months, 8 months, increased exudate and slough. And sometimes those are the type of stuff that are quite superficial. You cleanse them, they disappear. Next dressing changes, they come up again. So just think, where is this coming from? And the wound is stagnant. That is biofilm-related wound infection. Erythema at the wound margins, malodor, high bacterial load. We need to recognize them because they can keep the wound in a low inflammatory stage and keep that wound open. And again, it can tip into spreading infection or systemic infection. Critical complications of wound infection, if we don't get it right, these are some of the critical complications: necrotizing fasciitis, so necrotizing infection, osteomyelitis, a bone infection. This can be catastrophic. This can lead into potentially a loss of a foot or a loss of a limb. And sepsis, okay, something we need to be vigilant about. Now, this is not a sepsis session, but something that we need to be aware of. What are the signs and symptoms of sepsis? I think I mentioned earlier about tachypnea, high heart rate, increased breathing, shivering, fever, very cold temperature, high heart rate, clamminess, local infection. That even includes diarrhea or sore throat or respiratory symptoms. Be vigilant of those. And we need to act rapidly if we're seeing some signs of sepsis for a particular patient, because this can easily tip into death. So that is wound infection. And that is just a whistle talk about wound infection, really. So hopefully that gives you a flavor or give you some indicators on how to identify localized wound infection, potentially biofilm-related wound infection. We need to manage those, I think, from a nursing perspective, from a wound care perspective, so we don't tip towards the other end of wound infection. I'm going to touch on slightly about wound swabbing, because sometimes it's very common, or that clinicians, when we're dealing with wound infection or when they are assessing wound infection, they're relying on microbial analysis of wound swab. I've been running a clinic for almost 2 years now, and I think I can only remember possibly 3 or 4 times that I've asked for a wound swab. And the reason why I asked for a wound swab is because I was seeing a spreading wound infection, and I want to know what type of antibiotic is suitable to a particular patient, because antibiotics are specific and targeting. Outside of that, we must rely on accurate clinical assessment, those signs and symptoms of infection. So don't let your wound swab dictate your diagnosis of wound infection. Wound swab will only tell you what type of organisms and what type of antibiotics would be suitable for specific patients. But there are some good reasons why we take a wound swab. One, and that list is acute wounds with classic symptoms of wound infection, particularly acute wounds that involves potential surgical interventions with involvement of either, for example, metalworks, hip replacement, knee replacements. If they're showing some signs of wound infection, wound swabbing can help in identifying the right type of antibiotic that the surgeons can consider. Chronic wounds or hard to heal wounds that tipping into the spreading and systemic infection, because we know we need to know what type of antibiotics we should use. Infected wounds have failed to heal despite best efforts and antimicrobial treatment. Okay, so those are just some examples of rationale on why we take a wound swab. If that wound swab, or if we think the wound is locally infected and we need to treat them. There are 5 rights of antimicrobial stewardship that we need to consider. We need to get the diagnosis right that yes, it is a true local wound infection. We need to know what type of antimicrobial treatment we should use, and that delivery system. Okay, so what type of wound preparation we should be doing as part of the antimicrobial treatment. Do we need an ointment base? Do we need a more absorbent foam antimicrobial to use to absorb and retain that wound exudate? When to initiate it? Obviously, right there and then. If you got access to the product, thereby access to the product is important. The right antimicrobial doses, something that you have to be aware of. Some antimicrobials out there in the market will limit in terms of how many grams you can apply to the wound bed. So we need to know that. And the duration. How long are you going to administer antimicrobial dressings to specific wounds that you think is infected? So let's look at the preparation element. So we've done the assessment. We know locally infected. We've considered the fibroids, and we now need to look at the wound to say, right, how can I prepare this wound? Preparation is key when we're managing wounds, not just for prevention and treatment of wound infection, but in daily practice when we're delivering wound care. A significant proportion of the patients that's been referred to me that's difficult to heal or hard to heal, what I've noticed is the lack of wound preparation. I don't know what happened to clinicians nowadays, but they're scared of touching the wound for several reasons, and I don't know why. And I'd like you to change that mentality this evening. Okay, when we see the wounds, when we see devitalized tissue, when I see devitalized tissue, is those slough, softening necrosis, for example, some signs of biofilm, that film or coating over a granulation tissue. It elicits almost like a sheen or a shine over a wound surface, not just a slough, hematoma, hyperkeratotic edges, debris at the wound bed. We must remove them. I always maximize that visit to the patient when they come into clinic. They have to have a thorough wound preparation. Otherwise, if you've got a wound bed covered with devitalized tissue, your treatment will not going to be effective because that treatment will not be delivered to the wound bed because it is being blocked by devitalized tissue. Thereby, wound preparation is important. If we don't remove those non-viable tissue, there can be a portal of infection. Bacteria will proliferate. Localized infection can tip into a spreading infection. And remember, from a statistics perspective, 80% of non-healing wounds may contain biofilm. Some experts will even go as far as almost all hard to heal wounds are infected with biofilm. And if we are suspecting a biofilm-related wound infection, wound preparation or wound debridement and cleansing is absolutely key or a cornerstone in managing those type of wounds. What you can see in the slide now is the evidence. This is the evidence done by Wilcox, looking at the benefits of debridement in comparison. So these are diabetic ulcerations. They were looking at mean healing rate. One group debriding it once a week. The other group is debriding it every 2 weeks. And what they found, wounds that's been debrided regularly once a week healed faster, 3 to 4 times faster. Now, I'm not surprised because I see this day in day out in practice. From your perspective, if you're listening here and you're just thinking, well, I don't do much of a wound preparation. I just use a gauze. I just gently wipe that wound bed, tender, painful, devitalized tissue. I'm scared of what you're going to do. Highly likely you will have a delayed wound healing. We need to change practice now. And that means considering reaching for those tools that helps us on when we do wound cleansing and wound debridement. And when I say tools, and I think some of the barrier why clinicians don't do wound preparation well is because they feel, well, I'm not allowed to do that. I need certain element of competencies. No, you don't. Okay. In terms of mechanical debridement, when I say mechanical debridement, is using a tool, rubbing it over a wound surface, That could be in a circular manner, trying to remove those loose contaminants and devitalize tissue is what I call mechanical debridement, or autolytic debridement using a dressing to soften those devitalized tissues. Anybody can do it. Okay, you'll probably be familiar, or you probably have some tools that you use in clinical practice. If you do and you don't know how to use it, reach out to the company. Now, here at Colplast, we've got a product called All Prep Pad that is suitable for mechanical debridement. Now, I use it in my own clinical practice regularly, and I pass it on to my colleagues, the healthcare assistants, to use. So a healthcare assistant can use it with appropriate brief training, just show them how to use it, and equally registered, unregistered specialists as part of their wound preparation and or wound debridement and cleansing routine. Let's get cleaning, get those wounds prepared. Okay, it's important. So this is what an OPREP pad would look like in clinical practice, the image to your right. So it's got a gentle side for cleansing and capturing some of those loose debris following debridement, and the black side is a little bit more abrasive area where we can really do a thorough and a good debridement to remove those devitalized tissue and to really remove those microorganisms that are clinging on at the wound bed. Because the only way, particularly from a biofilm perspective, to remove them is to physically remove them from the wound bed through using a tools. Okay. Following doing that, I will encourage you to apply a wound dressing. That potentially will retain that bacteria, or if you think that there's some signs of local infection, a dressing that's got some antimicrobial property. So again, assess, prepare that wound well, remove those devitalized tissue, and treat them well, depending on the signs and symptoms. Okay. How often are we preparing those wounds? Let's do it repeatedly and regularly when there is a need for it. We know that if we do it regularly, we get the speed of wound healing. But there's some precautions as well in terms of what we need to be vigilant about when we're talking about wound preparation. We need to be cautious with patients with diabetes, particularly if we don't know if they got diabetic foot ulcerations or any wounds in the lower limb and we're not familiar with the arterial flow. We got concerns about poor localized perfusion. We must avoid debridement until we're fully assured that there's good vascularity of the limb. If they're taking high dose of anticoagulant, or if they are immunosuppressed and they don't have the ability to heal the wound, but this is more about management rather than healing, because you might end up having a bigger wound if you're not cautious. So those are some of the precautions, or I would say contraindications of wound debridement that we need to be aware of. Treatment, we need to manage those wounds with a dressing that is suitable, that can handle and suppress biofilm formation at the wound bed. Here at Colplast, we have the biotin silicone AG. It's got a sustained release of silver, slow release, that will manage wound infection at the wound bed. So after your wound preparation, you've done what you could, you've done a good job. And if you think, right, I need to manage the bacteria, make sure that you use a dressing that's got silver component or antimicrobial properties to it to prevent that proliferation from happening at the wound bed. Okay. I am mentioning biotin silicone AG here purely because I work for Colplast and obviously work with your own local formulary, whatever antimicrobial dressings you have. But if you want to know more about biotin silicone AG, just reach out. There are different types of antimicrobials, of course, that are out there in the market. And I use some of them. I've used PHMB as well in clinical practice. So it's important we acknowledge them and we acknowledge those other types of antimicrobials, because if they don't work for certain types of antimicrobials, there's also a benefit of switching to a different types of antimicrobials. For the purpose of this presentation, I'm just going to focus a discussion on silver. I don't think we'll have time. The weather's lovely, okay, and I'm conscious of time. So how does silver work? How does silver work in clinical practice is the positively charged silver in the body of the dressing will bind against the negatively charged bacteria. And what happens is they block the transportation of oxygen and nutrients right into the bacterial cell and will cause bacterial death. And they also stop the replication of bacteria at the wound bed, thereby following your removal to wound preparation, because we can't see them. If there's some bacteria left and you want to suppress them and kill them, that's how the silver will work. It's been used in clinical practice for a significant number of years. They are broad spectrum. I haven't encountered a silver resistance in clinical practice, but again, we need to be judicious when we are using silver products at the wound bed. Now, I mentioned earlier when to use silver, particularly from a local wound infection. So this is what this slide is all about. I will touch on about colonization later, and when we're talking about prevention and looking at risk factors. When to stop antimicrobials, you probably would be familiar with the 2-week rule. So every 2 weeks, we must reassess that wound and we must reassess that care plan. After 2 weeks, if the wound is improving and there's no signs of wound infection, stop the silver. Okay, this is what antimicrobial stewardship means, the judicious use of antimicrobial. Stop the use of silver, be confident, optimize the patient. Okay, using silver 2 weeks, use small improvement, you're still seeing some signs of wound infection, there's evidence to suggest that, yep, you can carry on using silver for another 2 weeks. Again, review for another 2 weeks. But if there's no improvement of using biotin silicon AG, for example, I'm just thinking, right, I'm not seeing any improvement here, I'll use a different product. Or you're using a different product, PHMB, just thinking, no improvement, then I will use biotin silicon AG. So there's the remit about in terms of interchanging antimicrobials, depending on what you see as a clinical outcome. But review it every 2 weeks. Right, let's look at wound preparation in prevention of wound infection. Prevention is always better than cure. So when we are talking about contaminated wounds and we're seeing, remember those contaminated wounds, microorganisms proliferating, no host response, but they are replicating. Now, as an example, if you've got a patient who is immunosuppressed on cancer treatment, I've got one patient I've been managing now for 2 weeks, his surgical wound. He's on immunosuppressants. He is not optimized. He's feeling nauseated. He's not eating well because of all the medications that he's taking. So he's poorly nourished. So he's not an optimized patient, and his immune system is absolutely depleted because of the treatment. He's got a big his surgical wound on his stomach. So from my risk assessment point of view, I'm seeing an increase in bioburden at the wound bed. The wound exudate looks a little bit milky, almost purulent, mild malodor, and he's seeing some elemental pain. So not a true signs of localized wound infection, but I know the bacteria is proliferating because they're making sure, well, they're maximizing what they can do purely because the patient is not optimized. Thereby, I'm using all prep pad to this particular patient to remove those bacteria, and I'm using antimicrobials almost as a prophylaxis to avoid replication of the bacteria and manage them at the wound bed. There's some other cases, if I'm thinking, right, not necessarily an antimicrobial agent that I will need, a dressing that potentially with properties that would trap the bacteria and retain that bacteria at the body of the dressing, just like a biotin silicon, it's got that property in terms of retaining wound exudate and bacteria, based on evidence about 99.98%. It would hold that bacteria at the body of the dressing and stops it from being in contact at the wound bed and keeping it locked away so wounds can heal normally without the risk of wound infection. But again, crucial part is wound preparation and then choosing the right treatment. Do you need medicated treatment or do you need non-medicated treatment? I'm ending it now because I want to make sure that we have plenty of time to answer some of the questions. I'm conscious that I'm just talking at you, and I haven't even brought Charlie in to see whether there's any questions from the chat. So I'm going to start presenting now. Thank you very much all for listening. Charlie, is there anything on the chat?
That was absolutely amazing, Rommel. Thank you so much for that. You were so engaging, and there's been lots and lots of things in the chat, which most of which I think I have answered.
Oh, thank
Um,
you.
a few people saying that they've used all prep pads in practice and they've found that really helpful,
Good to know.
particularly with patients that have got hyperkeratosis.
Yeah,
People have found that it's helped to reduce some of that itchiness, so that's brilliant. Lots of questions around when is the right time to use an antibiotic versus an antimicrobial. So I have gone over that in the chat that,
okay, good.
when we are seeing local signs of infection, it's an antimicrobial dressing that we need.
Yeah,
If that infection then starts to spread or becomes systemic, that is when we should be introducing antibiotics as well as an antimicrobial for that wound.
absolutely right. And I think be vigilant on those little hints of signs and symptoms that the patient, when they walk into clinic, they feel when they see you and they think, you know what, I'm feeling a little bit down, loss of appetite. So those are some of the classic signs that you're just thinking, okay, it's tipping now towards a spreading wound infection. This is the time when we ask the GP or you prescribe your systemic antibiotic to stop that deteriorating into a full-blown systemic wound infection. But yes, brilliant questions, guys. Brilliant
Yeah,
questions.
there's lots and lots of thank yous coming through at the moment, Ronwell, as well. And we've had there's a couple of student nurses that have been on
Oh,
that are in their first year. They found that this absolutely brilliant. So
no.
it was
Remember, guys,
incredible.
remember, guys, it is a multidisciplinary approach when we talk about antimicrobial stewardship. So, absolutely, student nurses, let's get into the antimicrobial stewardship mindset right from the get-go, because we have to do our bit really to prevent antimicrobial resistance.
Um, they're just thank yous that are coming through. So just a little
Good.
bit of information for everybody. You will get sent a copy of this recording. You will also receive a certificate and a copy of our antimicrobial stewardship pathway. As I said, it will be after the presentation finishes today, but it's not going to be immediate. It will be in the next week or so. We do have other webinars throughout the year, and I'm going to put a link in the chat for Coloplast Professional. If you go to that page, it gives you the option to sign up to any of our other webinars. We always run a daytime one and then we repeat it again in the evening, because I appreciate not everybody can get time out of work time to do it, and we really appreciate that people do this in their own time. So
Yes.
thank you all so much for joining, especially on
Thank
such a
you.
beautiful evening. And
Yes.
thank you, Rommel, for such a brilliant presentation.
Oh, thank you, Charlie. Thank you, guys.